Another very common complaint, people use it for just to describe a lot of different things. So again, asking people to describe consistency, how often, blood in the stool, other symptoms. So it's defined clinically as more than three or more stools a day with or without fever or cramps. So it can be acute, or it can be something that people chronically complain of. In diabetes, we see both. We see patients who, because of neuropathies and the effects on the gut, they may be chronically constipated, they may have chronic diarrhea, just because of the disruption in the nerves. It results from insufficient water being removed when the stool is going through colon transit. So it's the opposite of constipation, where you don't have enough fluid retained. Here there's not enough time because the gut is moving faster to absorb water. So we're either going to slow down the gut so that it can absorb it, or we are going to allow it to soak up more water. So those are the two. Most of our target. So most of the time we're going to be using these short term, but you will find people who need chronic medication to help with chronic diarrhea. So in looking at the agents, we have the bismuth subsalicylate. You're probably more familiar with it because of Pepto-Bismol, or kaopectate. So kaopectate is a clay, an absorbent clay that really looks gross, but doesn't taste too bad. The other are the opioid preparations that are on the next page, so loperamide and diphenoxylate. And then there's other agents that we can use, and we'll hit those very briefly. So bismuth salicylate, subsalicylate, is used, you'll see it with traveler's diarrhea. It can be used for any diarrhea. It is good at absorbing endotoxins, so that's why you see bismuth in those preparations for, or drug cocktails for peptic ulcer disease, since you're dealing with an infectious agent. The one problem or thing you have to keep in mind with Pepto-Bismol is the salicylate. When I was at your point and rotating through the hospital, we had several kids get admitted with salicylate or toxicity or salicylism due to Peptic Bismol. Their stomach was upset, patients just kept giving Pepto-Bismol. It's pink, it's over the counter, you know, what problem could it be? But I have seen children get salicylate toxic off of it. I haven't seen adults. The one thing to be aware of is that it will blacken the stool, it will blacken their tongue. So for some patients, it's a real surprise, and so they may call you based on that. I think the bismuth oxidizes, and so it leaves that black residue. So not wanting to use it with concurrent with aspirin. Now, if you have somebody who's on aspirin for cardiac disease, that is not going to be enough. This would be more bigger doses. We don't tend to do that. In the past, rheumatoid arthritis, we used a lot of aspirin. Don't do that anymore. So usually that isn't so much the problem. But another place it could be is a lot of people like to use, what are those effervescent tablets? Alka-Seltzer. Alka-Seltzer has a lot of aspirin in it. I've seen people come in with gastritis and GI bleeds, adults, who got stomach upset, started taking the Alka-Seltzer, stomach got more upset, they used more Alka-Seltzer, and eventually got enough of a gastritis that they came in with minor GI bleeds. Okay, so that's the bismuth. The opioid preps are very effective. One of them is over the counter, that's loperamide or Imodium, and then Lomodal is prescription. Very effective, they slow the gut down, allow enough time for the excess fluid to be absorbed or water, and usually will stop the diarrhea within a short period of time. So these are more limited, they're usually for acute episodes. You will see patients who will use them long term. I had several diabetic patients that had, with their chronic neuropathies, had chronic diarrhea, and so they used it on a regular basis. But most of the time it's just for an acute event. So there you can see under loperamide, it comes as 2 and 4 milligram capsules. So it's 4 milligrams, so they take 2 capsules followed by 1 after each loose stool, and they give them a maximum of 16. Usually within an hour or so, for most times it's going to stop the diarrhea. The Lomodal is an opioid, but it has atropine added to it, and that has nothing to do with treating the diarrhea, but it does decrease abuse potential with the use, because they usually get symptoms from the atropine before they get any kind of high off the diphenoxylate. Again, you can overuse them and cause constipation. But again, if used like this and people are intent on just treating a symptom, for the most part, these are going to work well, and patients are going to feel much better. You can use bulk-forming laxatives. In this case, you could use something like a Metamucil, a bile acid sequestrant to bind up. And sometimes those are used in more chronic conditions. Probiotics have been touted in this area, but the data is really low. There's just not enough data and not good studies to promote it in everybody. People use it, but I can't tell you whether it makes a difference or not. Most of the time, these diseases are self-limiting, and so by the time they're getting better, and they attribute it to the probiotic, it may not have been to that at all. Okay, questions about diarrhea? Comments? Okay, traveler's diarrhea. Anybody ever gone outside the United States and gotten traveler's diarrhea? Zane says yes. Yes. Okay. So did you take stuff with you? Did anybody give you stuff to treat it with? That's common.
I forget what I got treated with, but the last time I was in Iran, I had it really bad, and it might have been food poisoning. I don't know, but we actually had to cancel our flights because I was like not holding any water down.
Wow.
Yeah.
Wow.
So it was pretty bad.
Not uncommon. When was the onset? How long were you there before it happened?
I was there a total of 3 weeks, so it was like that last week, right before that last week it started, and it was like a solid week-long event.
Yeah, how did they treat you? Did you get treated?
I can't remember, honestly. I know I got a shot in the butt. But I don't remember taking anything oral.
Okay, probably couldn't keep it.
Yeah.
Well, were you vomiting too? Just
Yes.
diarrhea? Oh gosh. Did you ever figure out what you thought it was?
No, I haven't really thought about it since I got arrested until just now.
Okay, Amy, I saw you shaking your head.
Oh, yeah. My aunt prescribed me some pills when I went over to Vietnam just in case I got traveler's diarrhea. And I think it was just from, like, the ice, because they didn't use, like, bottled water ice. They used, like, normal ice, ice over there. And so
Got it from that. So how long did the symptoms last?
actually not too long, just because I had the medication on hand just in case. So thankfully that was there.
Do you know what they gave you to take over?
I don't know. She just said, take it. And you'll probably experience it, and I did. And I was
So she
very-
prescribed it so you could treat, not so much prophylax. You
Yeah,
didn't-
not prophylaxis.
Okay.
Yeah.
Anybody else have a story, Sonia?
When I studied abroad, our whole group got Cipro as like a
Oh, okay. To take with you?
to take with us from here, like all the because you have to see a doctor before we went. And I know like 90% of us got a bottle of Cipro from our doctors.
Did you have to use it?
I didn't, but
Oh.
and he gave us, for me, my doctor gave me a list like for vomiting, for UTI, for traveler's diarrhea, like the dosage and how long I should take it. for each
Wow.
thing.
Wow, okay. Anybody else? Okay, you gave very good descriptions, so keep in mind their stories as we go through here. So 50% of people who travel to developing countries will develop diarrhea. It's very common. Most common cause is E. coli, and it's fecal contamination of the food. Other causes, so keep in mind, if people don't respond to treatment, Campylobacter is another very common bug. Could be Shigella or Giardia, Cyclospora or Isospora, which are hard to identify. So sometimes they're a rule-out bug that people will attribute the symptoms to. So the symptoms are due to the enterotoxins that the bugs produce, and that's what makes you sick. It's usually self-limiting, but you can hear by their stories that who wants to put up with that? They can last 10 to 14 days. So Zane gives you a really good description of how long it can be. So traveler's diarrhea this is its definition, is from when someone goes from a resource-rich setting, whatever that means, to during or within 10 days of travel to a resource-limited country or region. That's what's termed as traveler's diarrhea, so fairly broad. It's usually described as 3 different forms. So there's classic, moderate, mild. So classic is 3 or more unformed stools in a 24-hour period plus symptoms. Okay? Or people can have less diarrhea, fewer symptoms, or they can just have diarrhea and no symptoms. So there's different ways to do this. So so some people take preventative antibiotics before they go. So when they leave, they start a course of antibiotics and they treat it during the whole time they're there. So if you were in a very high-risk area, rustic setting, high risk for getting it, that might be a way to do it. It's not recommended for everybody. So that would be something that would be more limited. But giving people medicines to take if they get the traveler's diarrhea is a common practice. So prophylaxis is, and also think about it for people who have conditions where it could be worsened if they got that ill. So cardiac, somebody had IBS, just think that if you had inflammatory bowel disease or irritable bowel disease, how miserable that would be. So a disease on top of a disease. So those might be people, or someone who's immunocompromised, somebody who could be really in trouble from dehydration. Then prophylaxis may be warranted. And those would be Cipro, rifaximin, or bismuth subsilate, or subsilate, oh gosh, just bismuth. So the problem with bismuth is that it's the bulk, it's the amount that you have to take and the ability to carry that. So it comes as a liquid, it comes as tablets, but the tablets have to be taken 4 times a day. So it's about at least 8 tablets a day times however many days you're gone. So tablets might be the way to go. But the liquid, it's an ounce 4 times a day. So that's quite a bit of bulk liquid to carry. So those are prophylaxis, so kind of categorize it that way. Non-pharmacologic would be use common sense. But sometimes you don't know. Like I've been in Europe, but I didn't know you weren't supposed to use ice. I remember everywhere we went, you couldn't get ice. And so when we were in Czechoslovakia, so when we got back into Austria and Germany, it's like, found places that would give you ice. It's like, yes! I'm tired of drinking hot soda. So, but anyway, freezing does not kill those organisms, so the ice is the wrong way to go. And so remember Amy's story, because that's what happened to her. Food that's not prepared or washed properly, so peelings, fruit that you can peel, vegetables you can peel is better. One thing I didn't think about, but that was in the article I read, was that condiments can be contaminated. They said particularly in Mexico, they said avoid the guacamole because it's usually very high risk for contamination, as well as the pico de gallo also are the 2 most common condiments that are full of organisms. Safe water. So the more rustic of an area that they're going to, they either need to ensure that they have a safe source or teach them how to prepare or boil their water. So there's drops you can take. You can put bleach in water. You can put iodine in water. As Girl Scouts, that's what we learned to do when we would go on our primitive hikes or primitive camping. We would do iodine, or we would boil the water. I don't remember it tasting bad, but they said the bleach, you can taste the bleach. But it's only like 5 drops in a gallon. I mean, it's very little, but it'll kill all the organisms. So I guess better to taste bleach than to have the diarrhea. So things to kind of remember: boil it, cook it, peel it, or forget it. Or the 4 rules: peelable, packaged, purified, piping hot. So treatment. If you have to treat fluid replacement, restricted diet more means go with things that are easier on the gut. An easy one to remember is the BRAT diet: banana, rice, applesauce, toast. And then liquids, clear liquids. You want enough liquids to replace what you're losing. Antibiotics, so any of these can be used for quinolones up to 3 days. Azithromycin is actually the preferred. It's a single dose, preferred for kids, preferred for pregnant women. And then rifaximin is also one that can be used. You can use loperamide, so I told you don't use it if it's an infectious source, but depending on the patient's discomfort, you could use the loperamide. Avoid it if they think it's dysentery, so especially if they've been in contaminated water area, teaching them about what that would look like. Bloody stools and fevers, don't use it there. Not to continue to use it if they have abdominal pain or symptoms that worsen after 2 days. Bismuth, to treat symptoms, it binds up those endotoxins. It's a good drug to use along with the antibiotic. Spacing it out would be important so you're not binding up the drug as well. You can see the dose there. Potential for salicylate toxicity is there. Persistent traveler's diarrhea is lasting more than 2 weeks. So the recommendations there is think a different bug. So think Shigella or Giardia or the Campylobacter or Strongyloides. I mean, there's a whole list, or C. diff, depending on if they've been taking antibiotics. Potential could be that. Questions? Okay. Drug used for hemorrhoids. This is the most fun topic. Okay, so mostly patients are going to treat themselves. So if patients come in complaining of hemorrhoids, they're usually more severe, or they're not responding to usual, or they're having a lot of bleeding or pain. So those large veins those veins can enlarge and they can thrombose. That's usually where the most pain comes from, is a hemorrhoidal vein that has got a clot in it. So they get ischemic pain. So this can be very painful. If they're bleeding a lot, so patients who have hemorrhoids are going to have rectal bleeding. Usually it's minimal to minor. It doesn't upset most patients, but they could if they had a rupture or a major tear, they could have a lot of bleeding. So those are probably the more reasons that you are going to see folks. For the most part, they can treat them effectively over the counter. Most of the time, the mild to moderate hemorrhoids are going to respond to it. You need to think in terms of external and internal hemorrhoids. Some products are meant just for external, some are meant for both external and internal. Usually we like patients to self-treat for 7 days or less, and if that doesn't do it, then to see you. Most patients in the mild to moderate are going to respond to that kind of treatment. And then pregnant and nursing patients, we want them to just stay with the external products. So most of the time, what patients are going to be complaining of is itching or irritation, burning, inflammation. Those are going to be the most things that they're going to want to treat. We talked about the bleeding, the thrombose. Prolapsed internal hemorrhoids can also lead to a lot of pressure, bleeding, and pain for the patient. Okay, next page. So what is the treatment? Well, with the gut, it's almost always lifestyle. It's almost always aggravated by something we're doing. So people get hemorrhoids a lot because they are sitting all the time, or they are not very active, or they have a terrible diet and they're constipated a lot, so they strain when they pass a stool, and so that all aggravates those hemorrhoids. Very common during pregnancy. So, talking to patients about fiber. Fiber's wonderful. It comes in lots of great food, or you can take it as a supplement. So having them work up, if they're eating no fiber, then you gotta work it up. When you eat a lot of fiber and you're not used to it, what happens? You get gas and you get bloating, hurts. Okay, so upping the dose of, I don't know what I'll usually tell you in nutrition, maybe 5 grams every week. Increasing it up of the insoluble fiber will help. Drink plenty of water. In your elderly, this is gonna be, they're gonna complain to you about this a lot. So lots of water. As you get older, your thirst drive goes down. So encouraging them to make sure they're drinking plenty of fluid. The fiber supplements we talked about can help. Regular exercise does a lot to keep the gut functioning. So a walk can do miracles and wonders to help them with their constipation. So we're really targeting constipation as well here to help with the hemorrhoids. Drugs that cause constipation, cause diarrhea, anything that's going to chronically irritate that area is going to make the hemorrhoids worse. Fat, alcohol, because they make you more constipated. Okay, medications for symptomatic relief. So on the next page, there's a whole lot. So just some things to keep in mind. Mostly what patients want is relief from the burning and itching. So they want something that will be an anti-inflammatory or an analgesic. So almost all of them are going to have something in there that's like that. There's steroids, so there's hydrocortisone that's over the counter in those steroids that they can get. There are lidocaines or different anesthetics that they can get. Emollients will help because it'll soften up the tissue and make it easier to pass a stool. For acute pain, the hydrocortisone will help, the lidocaine will help, and they'll also shrink the hemorrhoids. That will also help for a lot of patients. There's vasoactive agents. Phenylephrine is in there. It's a vasoconstrictor, so it will help shrink the hemorrhoids and will help them with symptoms of pruritus and also pain. Antispasmodics can help just reduce the spasticity of the lower colon, and so it calms down the effects on the hemorrhoids. Sitz bath can help. I don't know how practical they are. You have to sit in warm water 1 to 3 times a day. I even found that they have a portable sitz bath that you can take to work. I don't know who does that. I don't know, but they're out there. There's protectants and astringents. So if you look on the next page, you can see all the different types of products. You don't have to, I'll put in the objectives which ones you need to know, but when you pick up a hemorrhoidal product, so the next time you're in the grocery store, go by and just look, they'll have multiple. So almost all products will have multiple different types. They'll have an emollient, they may have a protectant, usually they have multiple protectants. They have a local anesthetic. So usually they'll have some big product like an anesthetic, and then they'll have the emollients and protectants with them, or in addition to a corticosteroid. So what I want you to be able to do is look at a product and say, okay, I know that that's an anesthetic, I know that's a protectant, I know that's an emollient. Those are the kinds of things. Questions about those? The phenylephrine would be the one I'd worry about the most, in that if you've got somebody who's got cardiac disease, it's a vasoconstrictor, so you could precipitate problems if they're using it a lot. The other, if they use the steroid a lot, they can thin out that tissue and weaken the wall, intestinal wall or the anus, and make things worse. So those would be things to kind of keep in mind. Because if they're having to always treat, then looking at other methods to remove those hemorrhoids may be the better way to go. Questions about those? I'll write the objectives specifically enough so you'll know exactly what you need to know out of that chart. And I will be reasonable. Mostly I want you to be able to identify what things are or what it would be used for. Okay, last, irritable bowel syndrome. So irritable bowel syndrome is really a rule-out diagnosis. in the absence of any kind of organic or structural problem, patients have lots of GI complaints. It can be constipation, it can be diarrhea, it can be other symptoms that go along with it. Usually it's termed to be constipation predominant or diarrhea predominant. You'll see IBS-C or IBS-D. Okay? Often patients will have a mixed pattern, but they'll usually have one of the symptoms will be predominant. So we usually target our treatment after the predominant symptom. So the symptoms, there they are for you in the middle of the page: lower abdominal pain, bloating, distension, extreme urgency. So it's like when they gotta go, they gotta go. They gotta know where the bathrooms are. Mucus passage, diarrhea, so more than 3 times a day. Constipation, less than 3 stools a week. Upset stomach as well. Lots of other symptoms or other conditions can aggravate, so psychological symptoms, urinary symptoms. In a female, those organs are all very close together. Fatigue, dyspareunia, fibromyalgia. Diagnosis of exclusion, but there are, I assume they'll go over the Rome. Have you all done this one? No. Rome diagnostic criteria with you. I'm not going to worry about it, other studies. But the alarm features, I think, should be paid attention to. They're in the middle of page 31. So if they have these symptoms, then they need a workup about what is going on. So fever, GI bleed, anemia, so where they've got a chronic bleed, weight loss or anorexia, refractory diarrhea, family history of colon cancer, persistent diarrhea that leads to or puts them in danger for dehydration, and severe constipation or impaction. That little chart at the bottom kind of gives you the 4 different types that can occur: IBS, constipation predominant, diarrhea predominant, or the mixed pattern, or unspecified. Kind of gives you an idea of the amount of hard stools or diarrhea that they would have with each of those types. Okay, page 32, goal of treatment, focus on the primary complaint. If it's constipation predominant, then we're going to look at fiber. Okay? And we want at least 25 grams of fiber a day. And again, you can use a supplement, you can use foods, and I've given you kind of the relative dietary fiber amount in the different types of foods. Beans are huge in terms of fiber in grains. So insoluble fibers don't dissolve, the soluble fibers do. So you want a good mix of those, and the insoluble fibers will help, and that's what your psyllium in your polycarbonate, FiberCon, can't think of the engineering. Okay, so bulk producing laxatives, so for people who can't tolerate the fiber intake or won't eat enough fiber, you can add to with the Metamucil, and there it is, polycarbonyl calcium. All right, so just like if you eat more fiber, the same kind of symptoms can occur with them. Take with water. Both of those require at least 8 ounces of water, both the FiberCon and the Metamucil. Under the osmotic laxatives, these can be used. So Miralax is the one that would fall into this. And it can be used on a daily basis. And a lot of the patients will need to. So again, it's starting with the 17 grams of powder and titrating it up. Once a day is usually all that's needed. There is another product that's on the market, Amitiza. It is a chloride channel activator. This would be a drug that would be of last resort if nothing else worked. It's for women over the age of 18. So it's one of those odd designations. It's gender designation for females. The one thing is that it can cause a pulmonary complications, and they can develop dyspnea. So it's one of those drugs that is remained on the market because there's not much else that helps for people who have severe IBS, that is constipation dependent. dominant. For diarrhea predominant IBS, it's dietary modifications. It's taking away foods that they identify that make their symptoms worse. And then there's some that are listed. Caffeine, alcohol, artificial sweeteners. A lot of those artificial sweeteners are osmotically active sugars. And so they draw fluid in, and so they can make you, give you diarrhea. Fatty foods, lactose intolerance, their use of other herbal teas or herbal drinks should be also investigated. Here you would use loperamide or diphenoxylates to help control the diarrhea, just like we talked under diarrhea. You go on down underneath them, the doses are the same. Sometimes what they'll do is, if they are going into a situation that they know provokes, let's say that anxiety or severe stress causes them to have symptoms, then they will pre-treat with one of those drugs before they go into those situations. Or if they're going to be in an area where they don't know where bathrooms are, they don't know if they'll have access to facilities, then they can pre-treat. So some women will just use it PRN like that. When they're just not sure about their ability to care for themselves in situations. So they can be used like that and wouldn't be used on a regular basis. But sometimes they may have severe enough that it would require small doses throughout the day. The other are the bile acid sequestrants. It's thought that these women do not absorb them on a normal basis. And so the bile acids then lead to a persistent diarrhea. So by binding them up, they more stabilize out the stool and decrease the diarrhea. We also use bile acids in patients who have diarrhea associated with liver disease, or have extreme itching or pruritus with liver disease, because of those bile acids can cause that pruritic syndrome. But they are hard to use, and they require a lot of patient education. They're effective, but you really have to work with the patient. I think that's why a lot of times they are not used. Because you really have to work with them. How do you dose it? How do you prepare it? When do you drink it? How much do you drink? And titrating it just right, because they can cause a lot of constipation. So you can go the other way. So I think that's why they probably don't get used as much. A new one is Viberzi. If you listen to the TV, you'll see commercials for this quite a bit. These are opioids, or they work on opioid receptors. They're effective. They're more into the line. They're expensive. Their side effects are nausea, constipation, abdominal pain, but the worrisome is the pancreatitis that can occur. It's a low amount, but it is still an increase in risk. Pain and bloating. So for patients with IBS that have pain or bloating, you can use an antispasmodic. So these drugs are usually going to work on the smooth muscle of the intestines. Usually, mostly it'll be in the diarrhea predominant patients. So if you look down there, dicyclomine, it's been around a long time. It is a moderately effective drug. Same kind of side effects that we talk about with the anticholinergics. On the next page, hyoscyamine, Levsin or Anaspaz. Levsin comes as sublingual tablets. It comes as drops. So it's fairly versatile in the different ways that people can carry it or use it, either PRN or on a chronic basis. But they are highly anticholinergic, both of those drugs. So the side effects of anticholinergic side effects are common. Antidepressants. So there are low-dose serotonin agents that can be used. Remember, serotonin receptors are in the gut as well. Remember, sometimes we talked about there being that they cause constipation or diarrhea. So they use that effect on the gut serotonin in this instance. So it's usually the low dose. Again, it would be more into the line after the other agents that we've talked about. Other people will use the tricyclic antidepressants. Remember, they have high anticholinergic activity, so they take advantage of that. The only problem with that are in people who've got underlying cardiac disease. And it's also a suicide risk, because they're highly toxic in an overdose situation. But again, it's usually low dose with those drugs. They're very sedating, and they have a high hangover effect when you use them. So they're a little bit harder to use. They would be more into the line, but they're also cheap. So they would be very inexpensive agents to use compared to some of these. Levsin's been around forever, but it's like the only in its class, so it still runs about $100 to $200 per month. And I think that's it. All right, so I won't see you all until I guess next week, or maybe the week after that. So email me if you have questions about the material. I will let you know if I'm going to have more questions than 8, and I will also email you the prescriptions when I finish them up. Anything else that I have that's outstanding with you all? All right. Good luck next week. Enjoy yourselves. And you have a good one this week? Tomorrow. Okay. Good luck on that as well. Thank you. Oh, the books, if you will, Amber's got the cart outside, inside her office. She said you could